last speaker for this session, Dr. Prasanna Bharathi. She is an ophthalmologist and a medical retina specialist. She has an experience of 13 years in this field, and she did her ophthalmology from Osmania Medical College and then did her medical retina fellowship from Sarojini Devi Eye Hospital. And she's also specialized for retinopathy of prematurity from LV Prasad Institute. Topic is diabetes and eye.
Thank you, ma'am. First of all, I'm very thankful to the Idea Clinics for giving me this opportunity. So, effects of diabetes in eye. Why it is important? Because complications of diabetes will result in loss of vision. As all of us know, that diabetes mellitus is a group of diseases characterized by high blood glucose levels, and it's classified in type 1 diabetes and type 2 diabetes. And type 1 diabetes, 5% of the people with diabetes have this form of the disease. And type 2 diabetes, which is the most common form of the diabetes. So the study conducted by Shankar Nethralaya Diabetic Retinopathy Epidemiology and Molecular Genetics Study report shows prevalence of diabetes is 28%, and every third individual can be a person with diabetes. And prevalence of diabetic retinopathy in persons with diabetes is 18%. So every fifth person with diabetes can have diabetic retinopathy. So diabetic ophthalmopathy is a common sight-threatening complication of diabetes. I have grouped effects of diabetes on eye into extraretinal effects and diabetic retinopathy. So I am briefing the extraretinal effects of diabetes on eye. Coming to the lids, styes which are painful swellings commonly located in the lid margin caused by Staphylococcus organism, and they are treated by topical antibiotic drops and creams and oral antibiotics. And xanthelasmas are the collection of lipids under the skin which are treated by laser and cauterization. And collagen is the blockage of meibomian glands present in the eyelids which are located away from the lid margin. They are painless swellings. They are treated by incision and curettage. In uncontrolled diabetic patients, they are painful because of infection. So the other conditions like corneal keratitis, recurrent corneal erosions, persistent epithelial defects, and fungal corneal ulcers, which are commonly seen in uncontrolled diabetic patients. And cataractous lens is the commonest presentation in diabetes patients, especially snowflake cataract and posterior subcapsular cataract. The other cranial nerve palsies like oculomotor, trochlear, and abducens nerve palsies are commonly seen in patients with diabetes. So commonly myopic shift is seen in uncontrolled diabetic patients because of osmotic swelling of the lens. So this is the image, first image showing the central retinal artery occlusion. Because of the emboli in the retinal arteries, which are end arteries, there is ischemia of the retina which looks pale, and the cherry red spot in the center of the macula. Because a macula area is very thin, a reddish hue of the choroid is visible through this macula, which is responsible for the cherry red spot. And this image shows asteroid hyalosis, which are the cholesterol and calcium deposits suspended in the vitreous cavity, which are asymptomatic. If the patients have symptomatic features like floaters, then the patient should undergo vitrectomy. And this is a central retinal vein occlusion. Because of vein occlusion, multiple hemorrhages are seen all over the retina. The patient present with diminution of vision with macular edema, this patient has to be treated with anti-vascular endothelial growth factor injections and laser therapy. And the neovascular glaucoma, it is the complication of ischemic effects of the eye. So coming to the infectious diseases like endophthalmitis, which is a dreadful complication in diabetic patients, and orbital cellulitis, and mucormycosis, which is commonly seen in COVID cases because of uncontrolled diabetes and irrational use of steroids, which results in mucormycosis, is a fungal infection which causes internal and external ophthalmoplegia, proptosis, and ptosis. And herpes zoster infection may affect the trigeminal nerve. It also produces corneal ulcers, keratitis, which is responsible for the diminution of vision in patients with uncontrolled diabetes. So coming to the diabetic retinopathy. So I'm discussing about definition, epidemiology, pathogenesis and risk factors, classification and features of diabetic retinopathy, complications of diabetic retinopathy and their prevention and screening protocol of diabetic retinopathy. So what is diabetic retinopathy? It's a progressive dysfunction of the retinal blood vessels caused by chronic hyperglycemia. It can be a complication of diabetes type 1 and type 2. Initially, it is asymptomatic. If not treated, it can cause low vision and blindness. So what is the retina? It is a multi-layered light-sensitive neural tissue lining the inner eyeball, and light is focused onto the retina and then transmitted to the brain through the optic nerve. The macula is highly sensitive area in the center of the retina, which is responsible for central vision and color vision. The macula is needed for reading, recognizing faces, and executing other activities that require fine and sharp vision. So this is the image showing the retina. This is the optic disc which is showing the retinal arteries and veins, and this is the center of the retina macula. The center part of the retina is called fovea. There are 10 layers in the retina. So this is the image showing the healthy retina with optic disc and retinal arteries and veins and the macula. And this image, this is a retina with diabetic retinopathy showing multiple hemorrhages and hard exudates in the superior and inferior quadrants of the retina under the macula. So why diabetic retinopathy is a global scenario? By 2025, nearly 8 additional persons develop diabetic retinopathy every second. And 4.8% of the 37 million cases of blindness throughout the world is due to diabetic retinopathy. And every patient with diabetes have 20% risk of developing blindness when compared with the general population. And when compared with diabetic nephropathy and neuropathy, diabetic retinopathy is 10% increased risk of developing in the patients with uncontrolled diabetes. So this is the image chart showing that comparing the diabetes prevalence by 2020 and 2030, there is increased number of cases by 2030, approximately 79.8 million cases of the patients present with diabetes. So coming to the pathogenesis of diabetic retinopathy. So these are the retinal arterioles and venules. The anastomosis here forming the capillary bed. Because of occlusion of the retinal arterioles, it results in basement membrane thickening, endothelial cell damage because of increased accumulation of sorbitol levels in the endothelial cells, and increased growth hormone production because of increased insulin, which results in RBC changes like Rowlex formation, and platelet stickiness increases. And because of loss of pericytes between the endothelial cells of the capillaries, which results in the outpouching of the capillaries producing microaneurysms. So this microvascular occlusion produces ischemia, which results in increased release of vascular endothelial growth factors. These vascular endothelial growth factors helps in the production of new blood vessels in the retina that results in neovascularization. These newly formed blood vessels are very fragile. They are easily breakable, and the results in the formation of vitreous hemorrhage, which is responsible for the sudden diminution of vision in patients with diabetic retinopathy. And this vitreous hemorrhage on long run produces fibrovascular bands, which causes traction over the retina, pulling the retina, causing tractional retinal detachment, which is also responsible for sudden loss of vision in patients with diabetes. And this neovascularization, which is produced in the retina because of movement of vitreous from the retina to the anterior chamber, there is formation and development of new blood vessels even at the angle and on the iris, producing neovascular glaucoma, which is very painful condition. The patient will have increased intraocular pressures in this condition. And because of infarction in the nerve fiber layer, cotton wool spots are seen in the diabetic retinopathy patients. And because of microvascular leakage, it produces edema, hard exudates are seen, and even the retinal hemorrhages. So what are the risk factors which are responsible for the progression of diabetic retinopathy? Duration of diabetes is very important risk factor for the development of diabetic retinopathy. 90% of the patients of type 1 diabetes have a chance of progression of diabetic retinopathy after 15 years of duration of diabetes. When compared with type 2 diabetes, it's around 60% only the progression of diabetic retinopathy will be there. And in case of hyperlipidemia, hypertension, which is also a very important risk factor for the development of diabetic retinopathy. Smoking, obesity and anemia and pregnancy also accelerates the diabetic retinopathy. Because of poor metabolic control, the patient with HbA1c levels more than 7 gram percentage will have increased risk of development of diabetic retinopathy. When compared to male, female have just 1% increase in the development of diabetic retinopathy. Heredity, nephropathy, and also age at the time of diagnosis is very important. If the patient is diagnosed with diabetes before the age of 30 years, there is 2 times increase in the risk of developing diabetic retinopathy when compared with the patient who develops diabetes after the 40 years of age. So when a patient comes to the ophthalmologist, so he will examine the patient, he will check visual acuity, slit lamp biomicroscope examination, intraocular pressures, and gonioscopy before dilatation were indicated, and he will examine the patient whether he has iris neovascularization, whether intraocular pressure is elevated to rule out proliferative diabetic retinopathy, which is responsible for the loss of vision, and pupillary assessment for optic nerve dysfunction. So by thorough fundoscopy and stereoscopic examination of the posterior pole, we can diagnose the diabetic retinopathy. Dilated pupil is preferred to ensure optimal examination of the retina, because only 50% of the eyes are correctly classified for the presence and severity of retinopathy through undilated pupils. Because in mass screening, we will take images through undilated pupils. So those images, if there are any suspicious of having diabetic retinopathy, they have to be referred to the ophthalmologist. So coming to the classification of diabetic retinopathy, according to the International Clinical Diabetic Retinopathy Disease Severity Scale, patient with no diabetic retinopathy means he has no symptoms. And coming to the mild non-proliferative diabetic retinopathy, even a single microaneurysm qualifies for mild NPDR. It is the earliest ophthalmological finding of diabetic retinopathy due to loss of pericytes. So we have to examine carefully. This is the moderate NPDR, more than microaneurysms like cotton wool spots, hard exudates, hemorrhages, but it is less severe than the severe NPDR. And this is the image showing severe NPDR. So we have to follow the 4:2:1 rule, means all the 4 quadrants of the retina have at least 20 intraretinal hemorrhages, or 2 quadrants of the retina shows venous bleeding, or 1 quadrant of the retina shows prominent intraretinal microvascular abnormalities, and these irmas are seen commonly around the areas of ischemia. So even severe NPDR, we have to treat with pan-retinal photocoagulation. Proliferative diabetic retinopathy, proliferation means development of new blood vessels, whether it may be neovascularization at the disc or elsewhere in the retina. So when we call it as high risk PDR, when there is neovascularization of the disc more than half to 1/3 disc diameter, or any NVD with pre-retinal or vitreous hemorrhage, or NVE, neovascularization elsewhere, more than half disc diameter with pre-retinal or vitreous hemorrhage. It is very important. High risk PDR are the complication of uncontrolled diabetes. And these are the images showing, this is first image shows neovascularization of the disc mild, and the above left image shows neovascularization of the disc severe. Neovascularization elsewhere is mild and severe. So clinically significant macular edema. According to early treatment diabetic retinopathy study, retinal thickening at or within 500 microns of the center of the macula. So these are the hard exudates, what we are seeing here. So these are the edema of the macula. So this is the, when we call this a clinically significant, when there is retinal thickening within 500 microns of the center of the macula, or hard exudates at or within 500 microns of the center of the macula along with retinal thickening, and retinal thickening of one disc diameter about 1500 microns or larger within one disc diameter of the center of the macula. So the above image shows the mild diabetic macular edema, means some retinal thickening or hard exudates in the posterior pole. They are present distant from the center of the macula. Moderate diabetic macular edema, retinal thickening or hard exudates approaching the center of the macula, but not involving the center. In severe diabetic macular edema, there will be retinal thickening hard exudates but involving the center of the macula. So the prevalence of diabetic macular edema in mild non-proliferative diabetic retinopathy is 3%, moderate to severe is 38%, and proliferative diabetic retinopathy is 71%. So macular edema is seen in mild, moderate, severe and proliferative. So this is ischemic maculopathy. Because of non-perfusion of the macula, capillary dropouts, there is sudden loss of vision in patients with diabetic macular edema. This has to be treated with intravitreal triamcinolone and ozurdex injections.
Sorry to interrupt, Dr. Prasanna. Here on the panel.
Yeah.
We can just speeden up for lack of time.
Okay. So the complications of diabetic eye disease include vitreous hemorrhage, tractional retinal detachment, and neovascularization of the eye. So coming to the symptoms, floaters, diminution of vision, shadow, veil across the patient's visual field and eye pain. So important key factors include glycemic control and blood pressure control and dyslipidemia regulation and lifestyle changes. So coming to the screening schedule, which is very important. In type 1 diabetes, within 3 to 5 years after the diagnosis of diabetes, we have to screen first dilated eye examination and thereafter yearly. And coming to the type 2 diabetes at the time of diagnosis. So it's very important duty of physician, endocrinologist to refer the patient after diagnosing whether the patient is having type 2 diabetes for complete eye examination. It even is a duty of ophthalmologist to examine complete retina, peripheral retina examination. In pregnancy, prior to the conception and during first trimester, after that if the patient is having diabetic retinopathy, we have to check every trimester. If not, at the end of the trimester. This is the investigations. This is the OCT image showing macular edema, and this is fundus fluorescence angiogram showing the leakage in the retina, which is showing proliferative diabetic retinopathy. So this is the laser technique that we are using to treat the diabetic macular edema and proliferative diabetic retinopathy. So summary, only 5 to 10% of diabetic retinopathy patients are they're sight threatening. 90 to 95% of diabetic retinopathy patients are managed by good systemic control and regular screening. Glycemic control has metabolic memory and hypertension control lacks metabolic memory. So multifactorial approach targeting control of hyperglycemia, blood pressure, dyslipidemia along with lifestyle changes is recommended. So surgery is indicated in severe vitreous hemorrhage, tractional RD, and premacular subhyaloid hemorrhage. So alone we can do so little, together we can do so much. Thank you.